neuropathic pain. Before we start with the debate, we will first discuss about what is neuropathic pain. Neuropathic pain was first described in 1994, and it was defined by IASP as pain initiated or caused by primary lesion or dysfunction in the nervous system. However, the definition was felt appropriate, and it was revised in 2011, in which the word somatosensory was added to this definition, and since then it is being defined as pain caused by a lesion or disease of somatosensory nervous system because of the presence of sensory symptoms in these patients. Pain associated with the it can be because of the because of the disease or injury in either the peripheral or central nervous system. And in many of the cases, there is usually an absence of any stimulus. Another thing to note is that not all patients with neuropathic pain experience, not all patients with nerve damage experience neuropathic pain. These are the various terms we should know. In view of short time, I would not like to go into details of these terms. What is the difference between nociceptive pain and neuropathic pain? Nociceptive pain, usually there is a stimulus, noxious stimulus, and once the noxious stimulus is removed, the pain subsides. What are the various causes? Neuropathic pain can be because of traumatic origin, inflammatory, metabolic, autoimmune, chemotherapy induced, or the hereditary ones, or as neurologists we usually see it in cases of stroke or trauma, or in trigeminal or glossopharyngeal neuralgia. How to make a diagnosis? Most of the cases, this onset of pain is spontaneous without any stimulus, and distribution of neuropathic pain matches the degree of neural lesion. These patients may present either with the positive symptoms or negative symptoms, and as a clinician we need to demonstrate what the nerve damage or dysfunction in all patients, all these patients experiencing pain, to make the diagnosis. Diagnosis of neuropathic pain rests heavily on the demonstration of sensory abnormalities, and we need to, majority of cases we can treat only the symptom rather than the cause. This is a crux of this. This is the slide which is demonstrating the whole of this conference, and in this we will be dealing the medical management. And this special interest group on neuropathic pain are divided the various medical therapies available for management of neuropathic pain into first line, second line, and third line. These are the various options available with us. NICE guideline also recommended amitriptyline, duloxetine, gabapentin, or pregabalin as the initial treatment of neuropathic pain. The exception being trigeminal, in which the first treatment of choice is carbamazepine and oxcarbazepine. These gabapentinoids are third line drugs for the management of this pain. Now I call upon Dr. Abhishek, who will be speaking on gabapentin. After that I will call, because gabapentin came into the market first, pregabalin came later. That's why we will be discussing gabapentin first. Dr. Abhishek, please.
Good evening, respected delegates. Thanks for the opportunity to speak here. I'll be talking about the gabapentin in here. Management of neuropathic pain is multidimensional. It includes pharmacotherapy with TCAs, SNRIs, and calcium channel ligands, etc. Then non-pharmacotherapy and psychobehavioral. Now I'll be talking about gabapentin. It is an amino acid analog of GABA that is effective against partial seizures. It was originally conceived as a spasmolytic agent, but was later found to be more effective as an anti-seizure medication. It is primarily used in seizure disorders, management of neuropathic pain, and vasomotor symptoms. Now talking about the potential mechanisms of gabapentin actions, the mechanism lying behind the pain relief is largely elusive. However, its action on the alpha to delta subunit of presynaptic voltage-gated calcium channels, causing inhibition of calcium currents and modulation of neurotransmitter release, is particularly thought as a mechanism causing pain relief. It also alters GABA metabolism, its non-synaptic release, or its reuptake by GABA transmitters. This effect is primarily useful in gabapentin as an anti-seizure medication. Now the preclinical data which we have available from the laboratory studies are gabapentin does not affect nociceptive threshold. However, it is effective in reducing both allodynia and hyperalgesia in animal models. It may have a selective effect on the nociceptive process involving central sensitization. However, there is no data to support that the effect of gabapentin on spontaneous pain in animal models. Now, is gabapentin an all-purpose painkiller? The answer is unlikely. It is not like a conventional analgesic like opioids that produce analgesia by means of elevating nociceptive threshold. There is no evidence that shows gabapentin to be effective in reducing nociceptive pain. With regard to neuropathic pain, there are few studies which show a small but statistically significant reduction of global pain scores in patients with diabetic neuropathy and post-herpetic neuralgia. Non-controlled open-label clinical studies support a role of gabapentin in reducing spontaneous pain and allodynia to both thermal and mechanical stimuli, regardless of the etiology. It appears particularly helpful in reducing paroxysmal pain with lancinating and burning quality. Now the side effect profile. The major side effects associated with gabapentin are dizziness, somnolence, confusion, and ataxia. Dizziness and somnolence, these are usually experienced by the patient during the initiation phase of the therapy. Later they subside. There are some sporadic cases of gabapentin-induced polyneuropathy and psychomotor agitation. There was one study directly comparing the side effect profiles of gabapentin and amitriptyline, and this study failed to prove a better side effect profile for gabapentin over amitriptyline. Now, is gabapentin better than other adjuncts when in pain medications? There is only one randomized double-blinded crossover study that compared the efficacy of gabapentin and amitriptyline on diabetic neuropathic pain. There was moderate to great pain relief in 52% of the patients. Since the study was a relatively small-scale clinical trial, it failed to prove an advantageous effect of gabapentin over amitriptyline. Also, the side effect profiles of both the drugs were not much clinically different. At present, there is more data is needed to support the notion that gabapentin is the first line treatment for neuropathic pain with a better efficacy, fewer side effects, and a favorable cost to efficiency ratio. This table was taken from the Cochrane study done in 2017 on around this study concluded around 37 to 40 studies, and the study found that there was it on using gabapentin at a dose of more than or equal to 1800 mg per day. Compared with placebo, the gabapentin fared better in reducing post-herpetic neuralgic pain. This table was taken from the same study for peripheral diabetic neuropathy. When gabapentin was given at a dose of more than or equal to 1800 per day, gabapentin fared better than placebo in the trial. Again, study from the a table from the same study. This table shows us the adverse events and withdrawals associated with gabapentin use at a dose of 1800 to 3600 mg per day. When compared with placebo, gabapentin had more side effects. Now, the same study, a different table. This table shows that when gabapentin was used alone or in combination with morphine, it fared better than placebo in controlling all kinds of mixed neuropathic pain. Now, this table is taken from study which was published in JAMA in 2019. This was a randomized double-blinded trial of gabapentinoid versus placebo for off-label treatment of pain. The study shows that the gabapentin is particularly useful in treating back pain or radicular back pain, diabetic neuropathic pain, but it is not useful in treatment of central neuropathic pain, traumatic nerve injury pain, or acute zoster pain. So in conclusion, gabapentin is a good drug and can be used to treat neuropathic pain. Thank you.
Now coming to Pregabalin. Pregabalin was synthesized in USA in 1980, and both of these drugs are gabapentinoids. Mechanism of action and the site of action is nearly the same. Pregabalin doesn't bind to both of them don't bind to GABA BZD receptors, or none of them form GABA. And this is the chemical diagram of GABA, Pregabalin, gabapentin. We can see that basic molecule is nearly the same. Pregabalin and gabapentin are extensions of GABA. This has already been discussed, and the point I want to highlight in this slide is Pregabalin is more potent than gabapentin, and that's why it's prescribed in lower doses. Coming to pharmacokinetics of Pregabalin, it's actively absorbed from GIT. Food may delay its absorption. Bioavailability is nearly 90%, and protein binding is 0%. T half is around 6 to 7 hours in adults and is less in children. Time to peak is around 3.5 hours when you are fasting, and after food it's 3 hours. It is transported actively across blood-brain barrier, and it undergoes negligible metabolism in the body and eliminated unchanged in urine. Dosing, it was first approved for clinical use by FDA and European Union in 2004, and generally it is started at low doses, and gradually we have to increase. Guidelines says 25 milligram per week we have to increase, and can be increased maximum up to 300 to 600 milligram per day. In various countries have different indications for using this drug for the patients, and this is according to Australia. This can be used only for refractory neuropathic pain not controllable by other treatment, and in epilepsy. However, in India, due to lack of any legislation, there are many off-label uses for both of these drugs. Response of this drug is not immediate like paracetamol. Like you give a medicine and within half an hour you will get a relief. It's not like that. Usually the response takes time, and the response patients gradually start getting the response within the first week after starting therapy. And how we can declare there is no response, and when we can declare it, it's usually at least 8 weeks of adequate dosing of therapy before declaring no response if response to relief of pain is less than 30%. These are the definitions which are used in literature to define the benefit of the drug. Moderate benefit is labeled when at least 30% pain is relieved, and substantial benefit of the drug is labeled when at least 50% pain is relieved. Coming to adverse reactions, incidence is very, very low, around 3%, and the common adverse effects are respiratory depression, especially when it is taken with other CNS depressing medicines, and suicidal suicidal thoughts or behaviors is also often found adverse event with this drug. Other common drug adverse reactions seen with this drug is dizziness, drowsiness, blurred vision, fatigue, weight gain, dry mouth, headache, impaired balance, and peripheral edema. And this I already discussed. Interactions coming to the important adverse effects is dose. It's a dose dependent, and fatal respiratory depression can be seen when it's administered concomitantly with other CNS depressing medicines. Hypersensitivity reactions as seen with any other drug is possible with this drug, and visual disturbances may also be seen. Pregabalin adverse effect is very, very less, or you can say nearly same as placebo at doses of 150 milligram per day. Higher doses are likely to produce higher adverse events. And this we can see nearly the same effect, same adverse event of 150 milligram per day with placebo. Coming to the overdose, overdose symptoms are usually CNS related, like dizziness, agitation, delirium, or headache, and some of these patients might have ECG abnormalities or GI upset or kidney failure. Management is usually supportive, and death is unlikely because of overdose. Are there any contraindications for using these drugs? Hypersensitivity, which is there with any drug. In cases with renal impairment like CRF, we need to do some dose adjustment, and patients with substance abuse, we need to be cautious while administering such drugs. How to, when the patient has got relief from the disease, can we withdraw it? Yes, we can withdraw it, but we should not never stop it suddenly. It should be gradually withdrawn. Drug interactions, especially with alcohol, people who take alcohol, especially in the evening, should be and taking the night dose of this drug, should be cautious about the CNS depressant effect of the dual combination. Thiazolidinones may enhance the fluid retaining effect of this pregabalin, and should be given carefully. Is it safe in elderly? Yes, it is safe in elderly, though symptoms like dizziness, somnolence, peripheral edema, they are slightly more commonly seen in elderly. From this discussion of we could make out there are a lot of similarities between the government in site of action, mode of action. Many things are nearly the same. But what are the differences? Differences are there in the dosing, are there in the potency. Gabapentin being slightly less potent than pregabalin. That's why gabapentin dosage is slightly more, 300, 400. Pregabalin is 75 or 150. Addiction potential of pregabalin is slightly higher because it gets absorbed quickly and gives quicker onset of action. However, FDA indications are of these two drugs are quite different, and this is again the same summary. And to this, I would like to conclude that both this pregabalin and gabapentin are quite effective in relieving neuropathic pain in various conditions. Now I request Professor Deepak Agarwal to kindly summarize and conclude about this debate session.